In the oral session, we've seen interesting data on neoadjuvant treatment. First of all, the NADINA trial. The NADINA trial is a phase III trial randomizing between neoadjuvant treatment with ipilimumab-nivolumab and adjuvant nivolumab. The patients in the neoadjuvant arm were treated with 2 cycles of neoadjuvant ipilimumab-nivolumab followed by lymph node dissection, and then their adjuvant treatment was depending on their response. The standard arm was just lymph node dissection and nivolumab. We've seen the EFS at ASCO. It looked really promising, and now we've seen the update with the distant metastasis-free survival. In the updated event-free survival, we saw a hazard rate of 0.32, which I think is really impressive. And the same holds true for the distant metastasis-free survival with a hazard rate of 0.37. This means that the EFS benefit translates to the distant metastasis-free survival benefit. So I think it's really good. The updated MPR rate, so patients reaching a pathological response or near pathological response, was 61%. So I think that looks really promising, and we're looking forward to the OS data. What we also saw in the same session was an update by Georgina Long of the pooled data of earlier neoadjuvant trials and patients treated outside of trials. I think there were 3 main takeaway messages there. We saw, looking at the 3-year RFS, that mainly the patients with a major pathological response, like I just explained, do really well with almost 90% RFS after 3 years. We knew that, but it's good to see how it translates to long term. We also saw that the combination is doing a bit better when you look at checkpoint inhibitors, so the combination of anti-CTLA-4 and anti-PD-1, ipi-nivo, or anti-PD-1 and anti-LAG-3, so rela-nivo, are doing better than anti-PD-1 alone. It's a difference of 5 to 10% in terms of EFS and MPR rate. So that's the second message, and the third is that BRAF/MEK inhibition is really inferior in neoadjuvant treatment. We already knew that, but that was confirmed. I think looking forward, what is important is to know which patients really need a combination neoadjuvant checkpoint inhibition, and which patients would do well with anti-PD-1 alone, because there is a difference in acute and long-term toxicity. So I hope we will be seeing biomarkers like interferon gamma to be able to know upfront which patients need more intense treatment. So looking forward to more neoadjuvant data.